Welcome, everyone, to this educational activity about GLP-1 receptor agonists and stroke reduction in type 2 diabetes. My name is Dr. Alice Cheng, an endocrinologist from the University of Toronto in Canada, and it is my pleasure today to be speaking to you about a guide to effective use of GLP-1 receptor agonists in people with diabetes at risk for stroke. So why are we having this conversation? And the reason is because there have been a number of trials of late that have demonstrated the benefits for stroke reduction with GLP-1 receptor agonists. And not surprisingly, then guidelines from around the world have adopted this information. And coming from Canada, I'm going to start by showing you a couple of Canadian guidelines. So on the left, we have guidance from the Canadian Cardiovascular Society, which is looking at the use of these therapies in type 2 diabetes, secondary prevention individuals, or high-risk primary prevention. And you'll notice the highlighted box on the bottom, there's a specific recommendation for GLP-1 receptor agonists to reduce non-fatal stroke risk. And on the right, we have the Canadian Stroke Best Practice Recommendations, which also emphasizes the importance of using antihyperglycemic therapies with proven cardiovascular risk reduction. It's not just the Canadians, but other countries as well, including the US, have also adopted these. So here we have the American Heart Association and American Stroke Association recommendations for secondary stroke prevention. There is recognition that glucose-lowering agents with proven cardiovascular benefit should be utilized in people. There's also a recommendation around the use of pioglitazone, which is a thiazolidinedione, recognizing the data for pioglitazone, but also recognizing the limitations of pioglitazone in terms of heart failure, as well as a potential bladder cancer risk, so much more limited. So therefore, there is definitely adoption from various guidelines for the role of GLP-1 receptor agonists for stroke risk reduction. And therefore, last year in 2022, I had the pleasure of being part of this writing group where we published a commentary in stroke, specifically speaking about GLP-1 receptor agonists for stroke reduction in type 2 diabetes, a call to action for our neurology colleagues. So let's get practical then in terms of how do we use GLP-1 receptor agonists in real practice. So first of all, it's important to remember that these exist as subcutaneous injections, either daily or weekly, as well as there's now one available as an oral formulation. The specific ones that have demonstrated stroke risk reduction are dulaglutide at 1.5 milligrams a week, as well as semaglutide at 0.5 or 1 milligram subcutaneous weekly. The advantages of this class of therapy is cardiovascular protection has been demonstrated, no hypoglycemia, no weight gain, and there is in fact blood pressure reduction, and of course, glycemic lowering. The downsides, though, are predominantly gastrointestinal in nature: nausea, vomiting, diarrhea, or constipation. And as I'll talk about later, this tends to be transient and is in about 20% of people who use the therapies. And currently, these agents are indicated for use in type 2 diabetes, as well as some of them in obesity. There are many GLP-1 receptor agonists available for use in type 2 diabetes, either daily on the left, weekly in the middle, or there's a once daily oral on the far right. But practically speaking, there are three that we tend to think about because of the stroke benefits that have been demonstrated, but also because of practical reasons. So we're less likely to use a daily GLP-1 receptor agonist now that we have weeklies available. So dulaglutide once weekly, semaglutide once weekly, both of which are subcutaneous, or semaglutide orally. So what can we do to mitigate some of the most common adverse events? Now, the most common adverse effects are gastrointestinal. As I mentioned, nausea, vomiting, or diarrhea. And that tends to be in maybe about 20% of people, which means 80% will not experience this side effect. It is typically transient, and that's why a slow titration upwards is a very important tool to help minimize this GI side effect. There are some dietary modifications that people can take, including smaller meals, stopping eating when they're full, which is something all of us should do, but we don't. We actually should not eat until we're full. We should actually eat until we're no longer hungry. Avoiding spicy foods can be helpful, maintaining adequate hydration, and then if necessary, antiemetic therapies can be used for short term because these side effects do usually go away. Hypoglycemia is not a common side effect of GLP-1 receptor agonists, and it is only an issue when used in combination with agents that can cause hypoglycemia, such as insulin or sulfonylurea. And I'll talk about practical tips around that later as well. So, what are some top tips when you're starting someone on subcutaneous GLP-1 receptor agonists? So, I think first of all, we should explain that we're using it for organ protection. I think it's important to include that because otherwise people will think if it's just for my sugars, if my sugars get better, I can stop. But in fact, no, I'm offering you this therapy to try to reduce your risk of stroke as well as cardiovascular. And therefore, as I say, as long as you have a brain and as long as you have a heart, we'd like to continue to protect them. Then I will counsel about potential side effects, which are, of course, the GI ones. And we've talked about strategies to address that. And then if necessary, I'll adjust other antihyperglycemic therapies, and we'll talk about how to go about doing that. And then the practical teaching of pharmacist or nurse or a diabetes team can do the teaching on how to do the subcutaneous injection. And then the specific dosing is shown here. So dulaglutide, we'd start at 0.75 milligrams a week for 4 weeks, then move up to 1.5 milligrams a week. And then if necessary, you can go even higher doses for further glycemic management. And then for semaglutide, you would start at 0.25 milligrams a week for 4 weeks, then 0.5, then if necessary, 1 milligram, and then again, a higher dose if needed for further glycemic effect. When it comes to oral GLP-1 receptor agonists, again, explain why we're offering it to them, same side effects, same adjustments if needed, but the way that the oral medication is taken is very important. The absorption of it is dependent on proper taking, and that means empty stomach with a sip of water and then waiting 30 minutes before you take any other food or put anything else into the stomach, and keep the pill in the blister pack until you're actually going to take the medication. The dosing of the oral semaglutide again needs to be titrated up. So 3 milligrams a day for 30 days, then 7 milligrams a day. And then if necessary for further glycemic effect, could then go up to the 14 milligrams a day. So what do you do with the other antihyperglycemic therapies? Because it's one thing to offer a therapy for organ protection, but the last thing you want to do is cause other problems. So if you have someone where, yes, they would benefit from a GLP-1 receptor agonist and they're on other antihyperglycemics, then the first question is, are they also on a DPP-4 inhibitor? These would be your gliptins. And if they're not, then go ahead and add the GLP-1 receptor agonist. However, if they are on a gliptin, then the gliptin can be stopped. And the reason is because the gliptins, the DPP-4 inhibitors, and the GLP-1 receptor agonists come from roughly the same family. They're cousins. So the GLP-1 is much stronger than the DPP-4. So therefore, the DPP-4 becomes redundant if you add a GLP-1. Now, I always say that if you forget to do this step, it's not a big deal. Our pharmacy colleagues will remind us. There's no toxicity. We can simply stop when we're reminded. But the next part is where it is important we play a role, because we want to avoid hypoglycemia, and that will only happen if they're on a sulfonylurea and or insulin. So if they're not, don't worry about it. Go ahead and add the organ protecting therapy, no adjustment to background. But if they are, then I would take a look at their A1C. And if their A1C is greater than 8%, you likely have room, in which case you can go ahead and add the GLP-1 receptor agonist and then counsel about the risk of hypo. And if they experience hypo, to then reduce the sulfonylurea or insulin. And if their A1C is lower, then that's where you may choose to reduce the sulfonylurea or preemptively reduce the insulin slightly. Or if unsure, that's where the diabetes team can be extremely helpful. And then, of course, ensure that the rest of the team is aware that these changes have occurred. Now, within that call to action paper that I mentioned earlier, there were a number of frequently asked questions that were addressed. And I'm just going to very quickly go through some of the ones here shown on the bottom. So do I need to be concerned about diabetic retinopathy? Because when these drugs were first coming out in one of the earlier studies like SUSTAIN-6, looking at subcutaneous semaglutide in their cardiovascular non-inferiority trial, there was a signal for increased diabetic retinopathy. But it turns out that it was not an issue of the drug itself, but rather the act of quick reduction in A1C in people with pre-existing eye disease. And we know this is true with insulin and with other modalities. So the practical tip here is make sure that people are getting their eyes checked on a regular basis, in which case any abnormalities can be identified. How can I address injection fears or concerns when recommending a GLP-1? Showing the pen device is very helpful. Having the person self-administer while they're in the office is very helpful. And then, of course, the multidisciplinary approach with other members of the team helping to support the patient. I find that once people actually see what the device looks like, once they've tried that first injection, that fear is completely gone. When should I not prescribe a GLP-1 receptor agonist? Well, given that one of the potential effects of the drug is to slow gastric emptying, if you have someone who has diabetic gastroparesis, then you may want to think twice about using a GLP-1, or in someone with active gallbladder disease, as one of the less common side effects could be gallbladder effect. So if they have active disease at the time, you may wish to avoid it. Then, of course, check your local product guidance around eGFR. And there are some subtle differences between the therapies, but these drugs are not renally cleared, so it is not a major consideration. And then finally, when should one have a follow-up visit after starting a GLP-1 receptor agonist? Well, typically it would be whenever you would see them in follow-up anyway, which would roughly be at the 3-month mark. So these are some of the frequently asked questions about prescribing GLP-1 receptor agonists. So therefore, it is important that we have this call to action to our neurology colleagues about the importance of stroke prevention in the management of type 2 diabetes, and that we have these therapies now, the GLP-1 receptor agonists, with proven benefit. So to summarize, GLP-1 receptor agonists are available as subcutaneous or oral formulations. Dulaglutide, as the doses shown for you there, as well as semaglutide, both subcutaneous or oral, are options to help achieve this. GI side effects are real, but they can be mitigated. They're not everyone, and they are usually transient. And I think starting low and going slow is the motto to help address this. And then when necessary, other antihyperglycemics can be adjusted, but only really if they're on sulfonylurea or insulin to avoid hypoglycemia, and then replacement of a DPP-4 inhibitor. So thank you very much for your kind attention.